Yes, it does.
Aren't you glad you came today?
She's got the high score, of course she's happy.
I wasn't feeling well yesterday.
Patients with WPW. Have the accessory pathway that bypasses the AV node. Okay. They are highly susceptible to tachycardia. It's too fast, not too slow.
I'm sorry. Thank you so much.
A delta wave. Straight goes right there with full Parkinson White. That is the slurring upstroke or downstroke starting the QRS process. The P wave at the end of the QRS is an, what do we call that one? Osborne wave, not a delta wave. An Osborne wave indicates they are cold, hypothermia. What would hypokalemia be? Flat T waves. High potassium is called T waves. Low potassium. And hypercalcemia?
Super spiked.
Calcemia, nope. This has to do with the QT interval.
Prolonged.
Hyper shortens it, hypo, like.
We obviously are all glad we did not have to answer that one.
So, lead one. Let's go this way, right? You're looking at the lateral side of the heart. Precordial leads do not view which part. Precordial leads are the ones on the chest. They don't see the inferior. They also don't see the posterior unless you continue them around, but posterior wasn't an option. V3 and V4 are anterior. The circumflex branch of the left coronary artery. Remember, left coronary artery comes out and it splits into the left anterior descending, the one down the front, and the one that wraps around the circumflex. So that would supply blood to the lateral, goes around the left side. Injury to the inferior wall, bottom part of the heart, would have ST elevation in T3 AVF. Those are the ones that view the bottom of the heart.
Just to be, the pathologic Q waves is like previous injury?
Yes. And that would show previous injury, and that's wider than one little box, wider than 0.4 seconds. The problem with that is it doesn't mean the heart attack was 10 minutes ago, it could have been 10 years ago. It just shows that there's previous damage. Axis deviation. So in lead one, the QRS is negative, which means what? Is it going towards lead one or going away?
Away.
It's going away from lead one. In AVF, it is positive. Is it going towards AVF or away? Towards. So we know it's going away from lead one, and it's going towards AVF. So it's shifted down into the right axis. A left bundle branch block. So you have a wide QRS. So we can't do this one because this is a narrow QRS. Can't do this one because this is also a narrow QRS. So it has to be a wide QRS, right? And for a left bundle branch block, turn signal. You're going to turn left is, okay. So you would have a terminal S wave. Remember the QRS, Q, R, S is down. So terminal S wave. R wave would be up. LVH. We add up V1, V2 QRS height with V5, V6 QRS height, whichever ones are bigger, out of 1 and 2 and out of 5 and 6, and they have to be at least 35 or larger. 35 little boxes or more. Which finding would make you suspect a posterior STEMI?
I think that
Posterior leads, yes, if I did V7, 8, 9 all the way around, but we don't have that. It's not a choice. So if I'm thinking the heart attack is on the back side of the heart, what would I see? On the front side, I would see reciprocal changes, or in this case, depression. Front side being be 1 and 2. It could be 3 and 4, but not elevation.
Yeah, this one's.
So what made you think? I know. ACS is a term to describe any symptoms, clinical symptoms consistent with a heart attack. Chest pain or pressure that goes away with nitro or rest is stable angina. Right? Chest pain on exertion becomes unstable angina. And ACS is any symptom of ischemia. Stable occurs after predictable exertion. Just talk about Levine's son, clutching their chests. Right? Presence of dizziness is because they have
Low cardiac.
reduced cardiac output. Which would be an anginal equivalent? Which of these complaints makes you think it might be a heart attack? Generalized weakness because it affects cardiac output. Statements regarding oxygen in the patient with a heart attack, right? Individualized and titrated to maintain a SAT above 94. Nobody missed that. When giving aspirin, you should swallow 160 to 325 milligrams of aspirin. This may have confused some of you. This is actually the dose if you read it, but everybody talks about baby aspirin, and 2 baby aspirin would be 162. But officially the dose range is 160 to 325. I'm not worried about them being hypertensive. I'm worried about them being.
I went with that one just because I figured you'd want to get vitals first. So I know it didn't matter if they're hypertensive or not, but that's just my thought process behind it.
Is aspirin going to influence their vitals?
No.
Okay, so that's why.
And that's why it kind of made sense. I didn't try to argue it, but since you pointed it out.
That's also why aspirin is probably going to be the first thing we give, because I can't give nitro without
Vitals.
vitals.
Yeah. I just figured you'd want to get vitals before any medication, but I know aspirin is going to affect it, so.
The most immediate forms for reperfusion of an injured heart attack. 2 ways you can do this. You can
That was my thought process.
spot busters, fibrinolytics, or go to the cath lab, percutaneous coronary intervention.
Right. So on this one, it says immediate, though.
Mhm.
We're not going to do either of those in the field.
But this is the key. Doesn't say you do this in the field. This is the key. We're reperfusing. That's not going to reperfuse. It doesn't get blood flow to the damaged area. It just prevents the clot from getting bigger,
I got you.
right? So that's what's going to get blood flow to those areas. Most significant risk of fibrinolytics is bleeding. You have to miss that. PCI interventions include recannulizing an artery by a balloon or stent. Okay, this is not PCI. This is actually CABG, a coronary artery bypass graft. You're doing bypass surgery. This one is, yeah, this is just you're visualizing, just to visualize. So I'm actually putting in a balloon or stent. Most common, which of the following is a common sign of left heart failure? Tachycardia, right? Definitely not cerebral edema, okay? Because left heart failure, the blood backs up to the lungs, not the body. Not JVD for the same reason. Those would be right heart failure, right? It's not backing up to the, you're not getting hypotension. You actually get hypertension with left ventricular heart failure, congestive heart failure. Pulmonary edema, you usually get hypotension. So tachycardia. Patients with a continuous flow ventricular assist device, some sort of VAD, usually an LVAD, do not have a pulse because that pump is running continuously, it's not pulsating. Really eerie when you have that patient and you're like, there's no pulse and they're awake and talking to you. Like, wow. And you try to, I can't get a blood pressure because there's no pulsations. You run an EKG and all you see is 60 cycle interference. So all your tests are out the window. Why? They don't have a heart working. They got a battery powered heart.
Someone with a gel in it. Is that or when it starts to work, gel comes out of it?
Not familiar with that one. Patients with right heart failure most likely have hepatomegaly, enlarged liver. Right? They're not going to get anything backed up to the lungs. That would be left heart failure. Cardiogenic shock without an arrhythmia would benefit from rapid transport. Process of aortic dissection begins when the inner lining, the insular layer, is torn, sir.
Okay, so this says the process of it begins, right?
Yes.
If it's all right, so the beginning would be the hypertension that
No.
causes the rupture.
The
Because-
dissection is the tearing.
Right.
You can't have a dissection until it tears.
But that's the aneurysm, not the tearing.
No,
How is it not? The aneurysm is the damage that's already done in the swelling of the vein.
stop. This is the blood vessel, and just for simplicity, that's the inner lining. Then you've got the muscle layer, and then you've got the outer line. Right, so all this is the vessel, and this is where the blood is in between.
Right.
We're good? Okay. So an aneurysm, the whole thing is weakens and bulges out.
Which causes the damage.
Would you let me finish?
Yes.
The whole thing is weakened and bulges out. So all these layers look like this. That's an aneurysm.
Okay.
A dissection is the inner layer tears, and now blood is getting in here, which also causes it to bulge out. They are different. So a dissection has to begin when the inner layer is torn. You can have an aneurysm without the inner layers being torn.
Okay.
Dissection literally means the tearing of the inner layers.
Right, that's why I put rupture, which is the tearing.
But hypertension causing a rupture is not how this begins.
Okay.
It begins when that inner layer tears. This could be from an aneurysm. They are similar, but they are not the same. Blood accumulates between the layers. Yes, that is getting worse, but it didn't begin with that. It begins when the layer gets torn. Hypertension is defined as a blood pressure of 140 over 90 or greater. Hypertensive emergency is 180 over 120. Okay, hypertensive emergency. 180 over 120, but there's also got to be signs of end organ damage. And it's causing problems to the organs. Abnormal neurogenic findings with hypertensive encephalopathy. Wow, big words. High blood pressure with some sort of condition in the brain. Right? Pressure causes the blood-brain barrier breach, fluid leaks out, causing increased ICP. Too much fluid is going into the brain. Candidate for fibrinolytics. If they've had chest pain for less than 12 hours. It's actually more than 15 minutes and less than 12 hours. Conscious alert, middle-aged man, complains of chest pain, nausea, blood pressure is 112, 90, respirations is 20, he's on hypothyroid, hyperlipidemia, synthroid, Lipitor, Cialis, and a baby aspirin. What's contraindicated? Nitro. That is a typical National Registry question. Yeah, because people will read it real quick and not realize, like, oh, Cialis. Something like that. Woman found her 48-year-old husband semi-conscious. Tells you that he had an episode of chest pain the day before, but refused to go to the hospital. He's now responding to pain. He's diaphoretic. Blood pressure sucks. His heart rate is elevated. Respirations are 28 and shallow, right? He's got a sinus tach. 12 leads shows evidence of myocardial injury. Got a heart attack, right? So, should we start an IV line? Yes. Give percent.
No,
Innovative.
maybe, but not yet.
Okay. Even that rate, ventilate him at 15, that's too fast. Okay, and then a dopamine drip. I don't like the percent innovate, because the breathing right here is wrong. Keep him supine. Inserting NPA, assist ventilations, yes, why?
Because it's
20
Shallow.
shallow.
All right, begin transport, start at IV, consider fluids, and start at dopamine infusion. Fluids first, then dopamine.
But
I would go more than this on fluids, but
my
that
question
was
on
reasonable.
my question on that is this is fluids and dopamine, like you're doing it at the same time. I thought you were
Okay,
going to try.
okay, no.
Okay.
I hear what you're saying. Place him semi-Fowler, semi-seated. What's wrong with that? Blood pressure is
No.
70. That's not good, right? Oxygen via non-rebreather. What's wrong with that? Breathing
Shallow.
shallow. Okay, so, all right. Elevate the patient's legs. Okay, bag him. Begin transport. Give 6 of adenosine. Why are we giving adenosine? I know his heart rate was 140, but we don't treat unless it's above.
150.
So I completely understand what you're saying with the do one then the other, not both.
Mhm.
But wrong rate, wrong positioning, wrong drug.
Okay.
It leaves you only one,
Option. Okay.
even though I agree, not the greatest, definitely wrong, definitely wrong, definitely wrong.
All right.
Yeah, so I do hear what you're saying. Not this question, but that is also a typical thing they will do on national exams. Is you will have that, sometimes you're like, it doesn't sound the greatest, but that definitely made this wrong, that definitely made this one wrong, you know.
So you say like wrong position, semi-Fowler, because of the blood pressure, but.
Well, also the non-rebreather makes this wrong. Two things that make it wrong. I can tell you right now, you see that word? It's a BBM, guaranteed.
I think a lot of people didn't pick that one because the weird, like 100 to 200 ml, like the weird dose of fluid.
I get it. I get it.
So 20 times shallow would be anxiety. Well, it doesn't necessarily mean.
Yes, but he is responsive to pain, diaphoretic, blood pressure, that's not exactly. If the only information we got was breathing 28 and shallow, yeah, you could make that argument. Way much, too much other
But
reason.
the other thing, he's still symptomatic. I know he would treat over 150, but he's symptomatic. His blood pressure's low. And then does he have his epi after epi infusion? I don't know.
Okay, so the epi infusion has the vasopressor, but the problem here is, right, why are we trying, is this a cardiac problem that's causing him to be shocky? No, it's gotta be above
150.
150 for me to treat it, and I'm gonna throw just another question to you there. How do we know it's even narrow? What if that was VTAC?
So you're saying the tachycardia is likely a result of the hypertension?
In this case, yeah, we don't treat tachycardia unless it's above 150 for that reason. If it's less than 150, it's probably a result of something else. If it's above 150, that could be the cause of what it is. And just precursor to next semester, kids, it becomes 180, babies, it becomes 220. So it's 150, 180, 220. So, other than that, in doses, the rules are the same. 55-year-old man, severe pain between his shoulders, ripping in nature, begins suddenly and intense, unrelenting. He's got a history of hypertension. What's going on with him?
Aortic
He's got an aortic aneurysm, AAA.
Oh, yeah.
Difference in the blood pressures between the arms is gonna be your biggest clue. Door to balloon time, 90 minutes. I assure you, all Volusia Flagler hospitals are grossly under that time. Like, they are crushing these numbers. I would venture to say, on average, Volusia Flagler County, you are probably under 45 minutes for most of them. You might have an oddball one here and there that takes a little longer. 49-year-old female has severe substernal chest pain. She's anxious and diaphoretic. 10 of you are getting a point.
That doesn't look good.
But for the future, just so you guys understand, right? How long does it take to do that?
Seconds.
How long does it take to do that?
A little bit longer.
A little bit longer.
She
Is
allergic to
this
aspirin?
going to change the results here?
No.
If she's allergic to them.
If she's allergic to it.
Or some ulcerative colitis.
Nitro's contraindicated for, of these choices,
Right side.
suspected right side heart attack. Chlorpulmonal, right side heart failure from pulmonary disease. 48-year-old man, history of hypertension as a headache. What is tinnitus? Ringing in their ears and blurry vision. Okay. Blood pressure 204, 120. This would be a hypertensive emergency, right? Are we getting end organ damage? Okay. Pulse rate's 100, O2 sats 96, closest hospital's 20 minutes away. All right. Are we transporting this guy?
Yeah.
Are we going left and side? Okay. Keep him supine. When their pressure is up that high, you actually want to keep them, their head elevated, 45 degrees or even higher if they'll tolerate it. High flow O2? Nope. Start an IV and give labetalol. Yeah, the beta blocker does help in situations like this. However, labetalol is usually only if, pre-hospitally, if you're going to do more than an hour. You're a little too close. So the best answer is monitor and transport. Not treating this. Just hurry up, get them to a hospital, yes, sir.
Just a question on this one, because I think I remember on the neuro worksheet, it was talking about for management of suspected stroke, which this kind of seems like it might be.
Okay.
For the positioning, it says supine, but it also says 30 degrees, like within the.
Head elevated 30 degrees. What they're talking about is if my brain is being perfused, in this case hyperperfused, the blood pressure is way too high, elevate their head. Just think of the opposite of shock. Shock, I want their feet up. Hypertensive or closed head injuries, I don't want their head up.
To try to relieve the pressure.
Unless I'm having to bag them, then I got to use supine. The other thing is, even though this is super up, neuro, he's conscious and alert. 7-year-old presents with pain in his legs while walking. After a few minutes, it goes away. He's got peripheral artery disease, some sort of artery disease. It's called claudication. You know, it's not a DVT, right? Because it goes away.
No. I went with the right ventricular failure, only because I recently had a patient who had a right, ventricular failure. Now, and he complained of walking hurting his legs, but as soon as he sat, it went away. Now, he also had bad pedal edema, so was that because of the
He
edema?
probably also has peripheral artery disease.
Okay.
You know, I mean, I get what you're saying with that patient, but that's like saying, well, I have some chest pain. That's my diabetes. I'm diabetic.
No, I got you.
It may not be related.
No, that's just where my brain went, so I was
Yep.
kind of curious.
Give him Narcan.
We didn't actually. We
House one there.
No.
Myocardial ischemia. Ischemia means what? Lack of oxygen. What is undergoing necrosis because of
Infarction.
This is infarction, so this one is ischemia.
It was split down the middle, so it's
I'm
still.
so mad.
Yeah. I agree.
Ischemic.
Ischemic is hypoxic. Infarction is damage, permanent damage like necrosis.
Was there a practice quiz question very similar to that one?
Think
But it
so.
said myocardial infarction instead of
I
ischemia?
believe so.
Yeah.
That's what it was. That's what it was. I didn't read that.
Crooked Ken!
Read the flipping question twice.
Time for it.
I don't do math.
Can we write this one?
Left main coronary artery splits into the left anterior descending and the left circumflex, or the circumflex. Cardiac related chest pain may be palliated. Palliated means what?
Make better.
Make better. by nitrite. I would also accept rest, oxygen, but those were not options. Area of conduction where the electrical activity starts is the pacemaker. On my other side is just a muscle cell. Electrical impulse is slightly delayed at the AV so that the atria can empty. It's got to pause to let the atria squeeze and dump blood into the ventricle. The farther you get from the SA node, the slower it gets, right? So it doesn't change the PR interval. That has to do with the AV node. And it's definitely not going to get faster. That's why SA is 60 to 100, AV is 40 to 60. Ventricles are further away we get, slower it gets. When putting the leads on, V1 goes on the right. Fourth intercostal on the right. V2 is on the left. Aberrant conduction is abnormal. Atherosclerosis is a process in which you get plaque buildup in the arterial walls, decreasing its elasticity. Narrowing its lumen, the tube in the center, where blood goes. Infarctions of the inferior myocardial wall are most often caused by inferior, that one is the right artery. The ones we looked at, the 12 lead, that is the only one that is the right artery, so we should check V4R, yes. Right atrium, right ventricle, part of the left ventricle are supplied by the right coronary artery.
Wasn't it on the last test?
Yes, it was. Bilateral pitting edema means both feet. Bilateral, right? Both sides? Pitting edema. Right? Well, it doesn't have to be feet, but bilateral pitting edema. What does that mean, pitting? You stick your finger in, it takes a long time. And we document that by plus and however many seconds it is. So like +3, +4 is like 1, 2, 3. That's a long time, isn't it? That's always a sign of right feather. It wouldn't be a major vein blockage because that would only be on one side. Because it's both sides. Right to heart failure. Atrial kick.
Got us.
Yeah.
This is the atria squeezing that volume of blood down into the ventricle. That last little bit. Kicks it down to the ventricle. Yes.
Gravity does the rest, you said, right?
Gravity does most of it. Blood goes into the atria and just kind of flows into the ventricles, but when the atria contracts, it squeezes the last little bit that's in there down. That's the atrial kick, yes. And you can technically survive without that, hence AFib. Right? We don't have atrial kick, just kind of the atria quivering. So,
Which increases pressure too a little bit, right?
it can.
Yeah.
It'll increase the volume in there, increase the Frank Starling mechanism to increase cardiac output. The people who need atrial kick usually end up with an AV pacemaker. Both the atria and the ventricles get paced. If they need that, their ejection fraction percent they pump out is usually pretty low. They don't do very well. That's the person who does this. Has to wait. Okay, I feel better. Wait. You know, like they're. We transport a lady to Gainesville. Her ejection fraction is like 9. Normal is 70. Yeah, it's the percent that it pumps out. She would scratch her nose and break out in sweat because her cardiac output would fall just from that exertion.
Jeez.
Yeah, she was going up there for actually a heart transplant, but she never got it. Pretty bad. How do you get a heart transplant? Somebody else had to die with a healthy heart that matches your blood and tissue types. Depolarization occurs when sodium goes into the cells. I'll be honest, this one surprised me a little bit. talked about that in Q1, we talked about that earlier this semester in Q2.
Doesn't, am I just remembering wrong?
Depolarization, now, that is still part of
That's what causes the
keeping it.
contraction.
Calcium is for muscle contraction. So if you remember, not the QRS, but the electrical change at the plus 30, 0, minus 90. And that wave that went, sodium went in, and what happened? It became suddenly positive charge, it depolarized, switched the poles. That was the sodium rushing in. And then you got the potassium coming out, the calcium going in, and then the reset. So those things happened, but depolarization occurred when sodium went in.
I think what threw me off is the part that says the permeability changes.
There's a lot of words.
Does it really change?
Words are tough. Yes, it's now letting, it won't let sodium in, and all of a sudden it lets sodium in. Because the electrical change changes, the permeability changes,
I don't know, but I guess we're about to.
whether it keeps it in or out. QRS of how big signifies abnormal ventricular conduction. I have a stroke. QRS has to be wider than 112. What may produce ST elevation mimicking a heart attack? Of these options, pericarditis. What are your other mimics? Left bundle branch block, left ventricular hypertrophy, pace rhythm, and ventricular rhythms. Everybody always forgets the ventricular rhythms. It's ventricular. Why are we even getting to a 12 when we got to fix this first? Right? And then paced rhythms, like why are we doing a 12 read? It's paced. Like it makes, you do 12 reads, just crumple it up and throw it away. It's worthless. Just gave 0.4 sublingual nitro to a 6-year-old with chest pain after 5 minutes. Pain has not subsided. You should first assess her BP. 67-year-old with shortness of breath, crackles, anxiety, history of several heart attacks, hypertension, which would have the most immediate effect. CPAP. In addition to high-quality CPR, which has clearly made a positive, measurable difference in survival. Defibrillation, that's why AEDs are everywhere. How does CPR change after an advanced device is inserted? That one breath every 10 to 12 seconds.
5 to 6, yeah.
Well, it's 5 to 6, and then it goes to 6 to 8. So it's not 10 to 12. We don't breathe faster. We're actually going to breathe a little slower once the advanced airway device is in. That hasn't changed, has it? We're just not pausing any longer for ventilations. Defib, a patient in the systole, is detrimental because you have to stop CPR. What do they need?
CPR.
CPR and other things like epi, treatable causes. Not going to pause the defibrillator. Attempting to resuscitate a 45-year-old man after 2 minutes, he is in asystole. After instructing them to resume CPR, you should do what next? Epi is more important than the airway. And I know what happens in the field. Everybody's like, I gotta get the tube, I wanna do this. And it's like, if air's going in and out, that's a very low priority. If air's not going in and out, that's a different story. So the most important thing after that would be getting the drug on board. 68-year-old woman, organized cardiac rhythm at a rate of 80, absent pulse. So what is that? PEA. Right? Treatment for her would include epi. Now, you can say, like, well, it could be an overdose. Narcan. Yeah, it could be, but every PEA patient gets epi. What should occur when integrating mechanical devices into your resuscitation? Right? Compressions should be continuous after an advanced airway device is inserted. Even if you're using one of these Lucas devices, auto pulse, or mechanical CPR devices, they have two settings. Right? Once you get an advanced airway, you just hit the button and switch to continuous. You should consider extending resuscitation and effort on a patient with refractory cardiac arrest if we've gotten ROSC at some point. So what they're talking about here is we're working the code. Whatever we did in our treatment room, oh my God, we got pulses, and then we lost them. Are you gonna call it? No, if we at some point got pulses back, we should definitely work them all the way to the hospital.
With the, I'm just asking, for the question where it says ventricular fibrillation occurred at any point during the arrest, so would that, does ACLS follow the same kind of protocol like we do, where if there's a change in rhythm from asystole?
That is your medical director.
Okay.
That is your medical director. American Heart will issue guidelines. There's a lot of, they can be very liberal sometimes with their guidelines. Most doctors, okay, those that I've communicated with and most of the literature I've read, if working a code and we started in a system and they've stayed in a system, nothing has changed. It could be 10 minutes, 15 minutes, 20 minutes based on the doctor's preference. That's usually a stop. We're not going to get them back. If we get them into something shockable, defib, pulseless VTAC, they're going to want, most doctors are going to want that patient worked on when possible. There's always exceptions. Again, my friend Jacqueline out in Montana, they'll work and work and work and work until they get ROSC and stable blood pressure on the scene, then they transport. And I say it's because half the time she's in such a rural area, their transport may be a helicopter. They do CPR in a helicopter. Not really. I mean, you might have a Lucas device or something on there, but it's still very difficult to manage. And, you know, everybody's in awe about the helicopters, and it's really hard to work in a helicopter. It's a super challenging environment. So for them, if they don't resuscitate them in the field, they're DRT, dead right there. They don't transport and work codes. They get pulses and then transport, or they don't transport. But she's also, you know, many, many, many hours by ground to a hospital. You know, I think she told me the trauma center's 5 hours. Her nearest, which is a little like standalone ER, was 2.5. Do you want to go there with the code? So, but yeah, in general, if at some point you got a shockable rhythm in your code, you're working it all the way. The chance of return of spontaneous circulation is best when minimal interruptions to CPR. Best things we can do for our patients. Yes, we do this, but that doesn't make the chance the greatest. The chance of it being the greatest, the most success, high quality CPR. Epi is given because it enhances coronary blood flow. It does not decrease coronary or cardiac irritability. That would be a lidocaine and amiodarone or MAG. It does dilate the bronchioles, but it's not why we're giving it in cardiac arrest. That's why we give it in allergic reactions, right? And it does not reduce cardiac afterload because it raises blood pressure, or constricts vessels. It increases afterload. Yes, ma'am.
I'm not gonna argue the question, I just want an explanation. So, it's a vasopressor, correct?
It is, correct.
So how, and it makes the heart work faster or harder by making it contract harder?
Better, stronger, faster.
Okay.
Think of like the bionic man.
So that's
It's gonna make
how-
it work harder, it's gonna make it work faster, but that's also making it more, it's damaged. So it's also gonna increase the irritability to it.
That's why I messed up then. I guess it's just because I know it, it vasoconstricts, so I would think.
Which is what this is. No, I'm sorry. It increases afterload, not
Right.
decreases.
I know it dilates bronchos, but okay.
But again, it doesn't apply in
That's not
cardiac
why we're
arrest.
using
Right.
it for cardiac arrest. I don't know.
It's like really crispy.
All right, I hate that question, throw it out.
So I know we haven't done peds, but I did leave this question in there on purpose. Okay, because you should, this is another, let's go through and talk through the question. Forget the answers for a moment. We got a person in cardiac arrest, they're in VFib. We've shocked them, and now we've done 2 minutes of CPR. What is the next thing we do?
Check their pulse or a rhythm change.
Right? We are going to shock them.
Again?
They're in VFib. When I look, is there ever going to be a pulse with VFib?
No.
So they're in VFib, we shocked. 2 minutes of CPR, the next thing is, we shocked.
Isn't the algorithm medication? Isn't the algorithm shock CPR medication?
If you actually read the algorithm, it's shock CPR, shock medication CPR. But that is written for the, we just arrived on scene. If you already have a drug route, yes, you get the drug going. But, right, what's more important at this point? Getting an airway or the shock?
Question.
Checking the pulse, it's VFib. It's not getting a drug route or shock. It has been 2 minutes. What happens every 2 minutes in VFib? We shock.
Just talking about the pediatrics here.
Mhm.
Usually a kid, it's not like an older person who has like heart problems, they've gone their whole life and now they have heart issues.
Mhm.
So my thought with the advanced airway was that, all right, if we shocked them, maybe they had something in their airway, and so we're gonna attempt to check the airway.
I understand what you're saying, and yes, pediatrics, usually the underlying cause is more respiratory, especially little kids like this. However,
Shock.
the shock is what's going to fix the VFib, and even if it is, if air is going in and out, it doesn't mean I need an advanced airway. And it doesn't say it is or isn't,
Okay.
but the
Okay.
shock is more important.
Where's the 70 joules come from?
So pediatric dose is 2 joules per kilogram for the first dose, because we haven't done peds yet. 4 joules per kilogram for the second dose. 70 pounds. How many kilograms?
He's 40 pounds.
40 pounds, excuse me. How many kilograms? Let's just cut it in half, 20. Right, it's gonna be a little less than 20, right? 20, 40, 60, 80, less than 80, 70? So, yeah, PD doses get a little weird with that, because it's 2 joules per kilo, 4 joules per kilo, and then third dose is between 4 and 10 joules per kilo. So not to jump to PALS, we'll just make it super easy. 2, 4, 8. You can figure out 2 pretty easy. The next one is double, and then the next one is double again.
So, I mean, because we haven't really gone over that, I mean, would IO be the next?
No, he's in VFib.
Right.
Shock, CPR, shock, CPR, shock, right? We shocked him. We did CPR. The next thing I need to do, it's been 2 minutes. Every 2 minutes, I don't care what everybody's doing, it's 2 minutes, we shock.
No, I know that, but
But how are we
supposed to know it's 70
that's the
joules?
correct dose?
Right.
I didn't
exactly.
know 70 was the right,
I understand that.
I thought shock.
I understand that. So you're saying because of this?
Yes, I
Mhm.
know shocking is right, but I didn't know 70 joules was right, so I put IO.
Yeah. No, I do. That's what I was gonna say.
All right. All right, fair enough.
Thank you.
So everybody's getting a point.
Yay.
So,
Thank you.
even if you got that right.
That's the 6 I needed.
After a while.
So then you go to the medication.
Yep, after a while.
I'm gonna be honest, I don't think I'm gonna get 5 more.
Anyone else?
2 of the 6 I needed.
Giving epi to a woman in VFib. The team continues to give CPR. After 2 minutes, she's still in VFib. You need to shock her, right? Continue compressions while it is charging. We don't just go, okay, charge. So push on the chest a little bit. You just shocked a woman in pulseless VTAC. After CPR for 2 minutes, you see that she's now in torsades and is pulseless. All right? It's been 2 minutes since your last dose of epi, so the next drug would be an antidysrhythmic, but because it's torsades, it should be MAG. Okay. I'm assuming somebody missed this part right there. If you had a pulse, then this would definitely be synchronized cardioversion. But you didn't have a pulse, sorry. Which of the following roles would the code team leader most likely do in charge of the ECG? Or following ROSC, patient is still comatose, what is most likely going to be performed? Targeted temperature management, like code cool, therapeutic hypothermia, hibernating them. Sir?
Just from my own understanding, a lot of us in lab, after our mega codes, hung drips immediately after we got ROSC and were told that that was correct. There was nothing in there about keeping them warm.
It depends on the antidysrhythmic. Well, in the textbook, which you were supposed to read those chapters,
Yeah.
definitely in there. It is a big thing. Why do you not do code cool here in Volusia County?
Because it's hot as hell?
No? Because you're so close to a hospital,
Okay.
right? Are most likely, are we giving a dextrose infusion? No.
No.
Right? Are we extubating?
No.
No.
We don't do that.
Giving an epi drip to get their blood pressure to 100?
Yes.
No.
That-
That's too high. We want
70.
pressures of 90 or 65 on an MAP. We're not titrating up to 100. We want just the minimums. So, okay. When practicing your code in the out-of-hospital setting, your focus should be on teamwork and minimal interruptions. Hyperventilation reduces coronary artery perfusion. It actually increases pressure. You put more air in the chest, increases pressure in the chest. And is not indicated if they've been in cardiac arrest for a long period of time. When performing CPR, chest compression should be at a depth of 2 to 2.4. I will admit the question did not specify adults, but clearly that's the lowest. Still adult? Not like you do that on a baby? Yes, sir?
I have a question about the in and out of hospital,
No.
the teamwork question. Might be a long shot.
Okay.
Isn't the most important thing early defibrillation on cardiac arrest?
Yes, but not early tracheal intubation. So half of that I can say.
Alright.
The other half. To perform high-quality CPR, you should work to achieve a chest compression fractions, the percent of time you're actually doing compressions of at least 60%.
So if you're doing 70, you're really doing that on that.
Yes, but the goal is at least 60 because you have to pause for ventilation, you have to pause to defibrillate, you have to pause to move them, you know. 60 is the goal. More than 60 is even better, but the goal is where or greater, 60 or greater.
It doesn't say the least percentage though, it just says what should you achieve or greater.
60 or greater.
But it doesn't say the least.
Doesn't have
70
to
or
say-
greater is 60 or greater technically.
No. Okay, no. You guys want to go with that? We can go with that. That's fine. Every single exam, following that same logic, everybody has to get 100. You want to go with that?
I don't even understand what he's.
Your logic didn't add up there.
Oh, no, because yours doesn't.
No.
So if you're saying this is better, and I'm not saying it's not better, but
Uh-huh.
the standard is 60 or greater.
Uh-huh.
The standard is 60 or greater.
Okay.
Okay. You want to argue that this should be a better answer? I'll use that same thing. You have to pass each block exam with the 70. But guess what? You want to go with the higher number? Now you have to pass each exam with 100.
I don't follow, but I don't want to argue,
Same
so
logic.
we'll just move on.
I'm sorry, take the loss. Unless you really want me to.
Nope.
Okay, I didn't think so. But I think there's about 20 people in this room, we're gonna take them out back and beat it. Two or more rescuers who do CPR, you should rotate every 2 minutes, 5 cycles, not 5 minutes. Delivering a shock to a patient experiencing cardiac arrest, you should next. CPR, yes, sir.
At what point do you take the 10-second to check for a pulse? It's right after you shock, pulse
No,
check,
no,
no
no, no.
pulses,
It
continue
is-
CPR?
You do not check, it's shock and you're on compressions. I really don't give a damn what that monitor shows. It could show a perfect sinus rhythm after the shock. We are on compressions. You check at the end of the 2-minute cycle if you see an organized rhythm.
This confused me only because when we were doing our codes, we shocked and they're like, steps that rhythm. Because we had this whole big thing and
So I need you to tell me which instructor that is so I can correct it.
so we're not checking for the rhythm after the shock. We're just-
You are on compressions. At the end of your cycle, that's when I'm looking at the rhythm and checking if it's an organized rhythm, if there's a pulse. Or if I suddenly got the spike in capno. Or they start moving and saying like, ow, stop, I'm okay, don't do CPR on me. You know, I've had that call. The drug overdose people are like trying to save their friend. Oh, stop, stop, and they're doing CPR.
Even if you shock them.
Bianca.
And you get pulses back, you're still within the 2 minutes.
You're not going to know you get pulses back until
You're still
those other
right.
things. Right. So even if we got the heart started, we shocked him and it went to something normal,
Keep going.
what's their cardiac output? What's their ejection fraction? It's
Nothing.
horrible. So we start doing CPR to help keep the pump prime. Now we see the spike in capno. That means the heart's pumping really good. So the capno went up. Okay, patient starts moving. Clearly, it's got to be doing pretty good. At the end of the 2-minute cycle, right? Last cycle, 28, 29, 30. Oh, that looks normal. Check for a pulse. Doesn't look normal. We're right back on compressions, or we're charging the defibrillator and doing compressions. But no, we don't check after the shock. We check after the 2 minutes. I know where this confusion comes from, and I'm apologizing on behalf of whomever said this in lab. I need to make sure they get corrected. 8 years ago, that changed in American Heart. 8 years ago, it was shock, check for a pulse, look at the rhythm, blah, 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 and then start CPR. So it's not like it just changed. It's almost a decade ago it changed, but old habits.
That was the last time I heard you do CPR.
Unresponsive apnea pulseless woman has a regular rhythm on the cardiac monitor. Condition information leading to arrest, which of the following would cause you to suspect cardiac tamponade. So what, any assessment makes you suspect cardiac tamponade is an H&T? Right. Absent breath sounds. Well, she's in cardiac arrest. She's not going to have breath sounds. Right?
Exactly.
JPD, okay. Unilaterally absent breath sounds, absent on one side. That would be what? Tension pneumo, okay. Cyanotic, okay. Collapsed veins. Well, for tamponade, she has to have JPD. It's got to back up.
What causes collapse?
Hypovolemia, we'll let out.
I took it out.
During attempted resuscitation, you note that the end tidal suddenly went from 17 to 40. What is that? Ross, we should. Pulse. Which is a peri-arrest condition, which is this is around an arrest time. They're about to code, right? Wow, their heart beats a little fast because they have a fever. VFib, that's persistent for 6 minutes. It's not peri-arrest, that is arrest. Bradycardia in the absence of chest pain. Okay. Good guy. Be super healthy. VTAC with a crappy blood pressure. They're gonna die. VTAC with a good blood pressure.
They couldn't die.
They're gonna die. That's the VTAC. Not good. Why do you check QRS first? If it's ventricular, we gotta go down. MAP, blood pressure 140/90. You add it up, divide by 3, you get 107.
106.
I couldn't.
Top number,
calculate it.
systolic, plus bottom number, plus bottom number, divided by 3.
I was like, what's the closest to the middle? Dude, I literally was, I wrote out like little tally marks. I was like, how many is in the middle of this? I was so, yeah, that was the closest one. That's what I did. I picked 101. I should,
Systolic,
yeah, I
diastolic,
should
plus
have taken
diastolic,
it.
divided by
And we want it to be, is there a goal we're looking for?
65.
Oh, this
is
formula
mean or
is better
zero
than the
pressure?
one I have.
What's the 60 to 90 thing?
I'm gonna have to learn it, but I'm not learning
Weigh that up.
I know the other one where you do it like a third.
Most
That's
Then I
for
forgot I can't calculate that.
cerebral perfusion pressure, yes. CPP, which is MAP minus ICP.
minus ICP.
Just saying it's 106, it's not 107.
Gannon for
Without the
Tachi.
106.6.
Gannon for
Just
Tachi.
saying.
106.6.
Why do you have to talk? Like, I was trying to
Me.
help them out, like.
Is it closer to 101 or 107?
I don't know who you're talking
The other way you can do this is diastolic, bottom number, plus 1/3 of the systolic minus the diastolic.
That's the one I did.
You'll get the same number.
That's the one that was in the book and I just rounded number.
Oh, I did minus signs.
So in this case, 90 plus 1/3
I was
of
literally
40
doing, I
minus
just did
90,
minus instead, and I had to do the
1/3
times.
of 50, which is 17.
Fucking
Six.
no, oh, I'd have to leave.
Six,
You
six,
in
six,
there?
six. Which would be,
No, I'm gonna get in the bathroom. I don't wanna touch my eye. I have to wash my hands.
or 16.66.
Yeah, and then,
107, 106.666.
I feel like there's
Or
alcohol on my.
140 plus 90 is 230, plus 90 is 320. Divided by 3 equals, what is up? Either way, you get the same answer. It's like saying you're gonna leave here and go to the beach. You're gonna go to Granada, you're gonna go over to Seabreezeburg. Either way, you're gonna get to the beach. Afterload is increased following alpha 1 stimulation because alpha 1 constricts arteries, raises blood pressure. Most common cause of cardiogenic shock? Heart attacks, without a doubt. According to the Frank Starling mechanism, okay, Frank Starling is what again? The stretch, the rubber band, right? Okay. So venous pooling of blood results in a decrease in preload. Is that Frank Starling? No. Increase in blood pressure causes a reflex bradycardia. That's Cushing's. Okay. Coronary artery perfusion is directly proportional to cardiac output. Yeah, that's true, but that's not Frank Starling mechanism. Right. The length of fibers determines the force of cardiac contraction. Yes. The bigger the fibers are, the stronger they're going to contract. Systemic effects of epi include increased afterload, raises blood pressure. Okay. Doesn't vasodilate, it vasoconstricts. It doesn't bronchoconstrict, it bronchodilates, and it increases preload. When attempting to resuscitate a patient in cardiac arrest, which would pose if you suspect that they are hyperkalemic. Of those questions, they are hyperkalemia, high potassium. Does that have anything to do with vomiting or diarrhea? No. That would be hypovolemia. Okay. Are they on blood thinners? It's not going to change their potassium, they're just going to bleed more. Right? Are they a diabetic? That would be sugar, glycemia. Right? Do they undergo dialysis? Why dialysis? They're in renal failure. And what do the kidneys do in addition to making urine? Balance potassium. They actually make urine by regulating potassium. All right, so I think there was 3 questions. I'll go back and rescore. Sir?
Could you go back, I think it was,